We're going to talk about blood level monitoring and genetic testing. As a toxicologist, I'm very familiar with the CYP enzymes, and I think there is a role. Just if you want my 2 cents or my final thoughts at the beginning, is I don't get genetic testing or blood levels for buprenorphine monitoring. I just do a simple urine testing. I always like to kind of let the cat out of the bag a little bit early on this talk, because some of the rest of the talk gets into a fair amount of detail in terms of pharmacodynamics, pharmacokinetics, testing availability, and things like that. So I always like you to know where I'm going to end up. I don't have any conflicts of interest. I do have some studies that are sponsored by the United States government and the state of New Mexico, as well as UNM, but nothing with private industry or anything. And as always, if you detect that I have some bias, whether that's towards industry, if that's cultural, racial, religious, or stuff, I would really appreciate the feedback so that I can always be improving my talks. Feel free to chat in the board. One of the things that we sometimes do, and with Snail and I, is that while I'm presenting, Snail will answer questions in the chat. And then if you guys don't come up with a case, you'll have one of Snail's cases, and then I'll sit and I'll get to write things in the chat. And it's actually kind of fun to do it that way too. For those of us with ADHD, or at least some level of it, we get multiple ways of being heard. So I'm just going to discuss some of the common testing methodology that is available. We're going to talk about some of the pharmacology of buprenorphine, and then to discuss the roles of genetic testing. So I think the first step is the screen versus confirmation testing. And using the terminology is actually really important here. And the technology that is used, the testing methods, limitations of the test are very, very different, just based on the simple word screen and confirmation. So screen typically involves in immunoassays. So the next time you're in the dollar store and you're walking through the medical aisle with the first aid kits and pregnancy tests, there's dollar drug tests there as well. This utilizes dollar store technology to do testing with. In the state of New Mexico last week, just as bringing current events into this, our governor finally signed into act a bill allowing fentanyl test strips and other harm reduction methods that we can be giving out. Again, it's a value to have this being cheap and effective, so that our patients at our addiction clinic are able to test the sample of heroin that they have to see, does it contain fentanyl, yes or no, because it provides them a safety factor. And so it's important that it's cheap. It's also really easy to use, which is, again, in the addiction clinic, a huge advantage for monitoring or screening for compliance and treatment. It's widely available. Every hospital that I've worked at, even standalone hospitals, seem to have this technology. The disadvantages are there is a lot of false positives and false negatives. If you spend time with me at the Poison Center, like, we'll get into all different things that some people start calling a false positive, false negative. And I'll be like, I think that's actually kind of a true positive, just based on the chemical structure and what it actually looks like. And you get into things like bupropion, which we're prescribing perhaps to treat an addiction, and it's FDA approved for nicotine use disorder. And that gives us a positive. Amphetamine. Why is that? Is that really a false positive? When I look at the structure, it's not so much to me. Now, confirmation testing uses a whole different level of testing, and it's gas chromatography, or gas or liquid chromatography tandem with a mass spectroscopy. For those of you who took analytical chemistry, we're dusting off cobwebs here. For those of you who didn't take organic chemistry, I'm going to try to distill this down. So think of making moonshine, or distilling alcohol, where you have a mixture of alcohol, water, methanol, other things. And what you do is you heat it up, and then it goes through this column of a copper pipe, and then it comes out on the other side based on cooling temperatures. What I've done is been able to separate out that heterogeneous, or those different molecules based on what time they're going to come out. That gives me one level of identification. The second then is mass spectroscopy, where we bombard those molecules with electrons and we break, or the term in the chemist uses, fragment the molecule, and then we look at the atomic mass. So it gives me kind of a fingerprint. And there really aren't false positives here. Sure, there's something like sledgeline that we write for Parkinson's that gets metabolized into methamphetamine that can show up as a positive for methamphetamine, but that's because methamphetamine really is there. That's just how it works. Unfortunately, the technology as described here and this two-part process, while generally computer-driven at this point, is very complex from a technical standpoint and really only available in reference labs. I can tell you in the state of New Mexico, there is no lab, or the only lab that is CLIA certified, meaning that they can bill Medicare and Medicaid, is here in Albuquerque for doing it, and they have a fairly limited panel of what they do offer testing for. And that's only limited to urine, but does not give us blood. And the importance here, and then the next slide, we'll discuss the pros and cons of blood versus urine. I'm not able to speak for Oregon or Oklahoma. If you guys have comments, I'd love to learn, and I'm trying to monitor the chat and talk at the same time. So these results, consequently, sending to a reference lab, aren't going to be available for 2 to 3 weeks, typically. There's some, as I alluded to, the differences between blood and urine. In blood, the serum concentration correlates with what we're seeing clinically. Hence, when you get pulled over for drunk driving, the answer of the state is we're going to get a blood level of alcohol to see how much was in your system. We're not checking your urine to see if there was alcohol in there. Now, because we're able to do correlation. One of the disadvantages of blood is if somebody had used recently, like last night, because I don't know, it snowed here in Albuquerque, and I needed a hot toddy to stay warm, that you're not going to see that done. So we take advantage of the urine because we have different alcohol metabolites that allow me to turn the clock back and check for the compliance with my patient with alcohol use disorder and the treatment of that. I see Dr. Bott is, I was just going to say that Snail is doing a great job answering questions. If there's anything that he wants me to, I would just kind of want to pause here, and if there's anything in particular that I wanted to, all right. So to me, indications in drug monitoring come down to about a few different areas. One is a drug that has a narrow therapeutic window. I think of a drug like digoxin would be a good example of this, or lithium for my psychiatry friends. That when we get outside of that, we can really run into toxicity relatively easily. If we have drugs with pharmacokinetic variability, we want to do drug monitoring there. So, and I put in drug-drug interaction. So the interaction between a PPI and I blanking on the generic name of the drug that we use for antiplatelet activity in the heart. We get around it with plazogrel. No, for just clopidogrel. There we go. And clopidogrel is the 2C19 inhibits the activity or the metabolism. Clopidogrel. I'm usually not this bad with names. Is something that I would look at. We also, with opioids in general, and I'm more the ones that are have a morphine codeine metabolic pathway, and the CYP enzyme has a fair amount of genetic variation, and it is helpful to potentially know what that is based on availability. Drugs that have a concentration that can be difficult to monitor clinically. And to me, again, one of the things going to honest question what we'll come up with is that when you look at the clinical trials of buprenorphine and you look to see how patients are doing, we're titrating the dose to um, to to the patient and how they feel, as opposed to a specific drug level for which they have, because there's a lot of variables that is more difficult to monitor with opioids, such as especially tolerance. And then if we have therapeutic or adverse effects, um, things like phenytoin, to me, fall into this category where they start getting toxic and we start having some adverse effects from it. So this is taken from the PCSS course, and as a reminder, buprenorphine is a partial agonist at the mu receptor, and while we get respiratory depression, we get a plateau response. Snehal and I are going to be starting a large NIH or NIDA study where we're looking at the higher doses, specifically 32 versus 16 milligrams for opioid use disorder treatment that I'm particularly excited about. And we'll let you know as soon as we start enrolling through the ECHO program on that. We also going up to 64 milligrams has also been demonstrated to really have respiratory depression similar to 16 milligrams. So there probably is appears to be some safety in an overdose as well. This is just also focused on respiratory depression because, again, as a toxicologist, I'm coming at you with I want to be particularly concerned with drug safety, and if my patient takes a double dose or does something outside of what I've prescribed, I want to know that they're going to be relatively safe in doing that, and showing why do we need drug monitoring, or make the argument of why we don't need it. This is going to get into the metabolism. For those of you who want to really nerd out and get into the CYP enzymes, 3A4 and the 3As are going to be the big ones here. Think of the 3A as we can inhibit some of the uptake by, like, grapefruit juice. This is when you need to gas on a drug. And the 3A4 metabolizes about 80% of different drugs out there. And as you can see, it has a variety of different metabolites to it. But norbupropion is a major one that we test for. And this is just a list of things. I don't want to scare you with words, but these are going to be inhibitors and inducers of the 3A4 metabolic pathway. Again, if your brain works like mine, you're unable to remember this in more than an hour from now. So I include that in the slides for reference if you're prescribing and you have a question on that. The 2C8 inhibitors and inducers are here. Rifampin is always a big one. So is phenobarbital. I very rarely see either of those prescribed here in New Mexico. And then our conazoles for different types of fungal infections tend to be big ones as well. So when we start looking at peak blood concentrations and this is what's generally reported in the literature as normal therapeutic for those of you who are wanting this. And I put this in here for you to as a reference range for patients compliant, but understand that these ranges vary because people are different sized people. We have some little people, we have some big people. We have people who metabolize faster, some who metabolize a little bit slower. And then it's also important to remember that we have in pharmacology peak and trough levels depending on how they dose. So most of my patients who are on 16, 24 milligrams, somewhere in that range of buprenorphine, they're taking their buprenorphine 2 or 3 times a day. If I get them in the morning before they take their buprenorphine, I'm really effectively at a trough level, and it may have actually a lower number than if I had just taken it an hour after they took their buprenorphine. So again, those are factors that I would need to take into consideration in interpreting the drug concentrations. As far as genetic testing, I've already kind of talked about some of the major or some of the drug interactions. Recognizing that pregnancy also increases drug metabolism, and I think those of you who are in, work in methadone clinics, we recognize that because methadone is metabolized by 3A4, and we end up having to increase the dose of methadone for patients who are pregnant because we've increased the metabolism of methadone. And so it's not that the patient has a higher demand for it, it's just they're metabolizing it faster. Conversely, post delivery we're able to work on decreasing the dose because we know that their CYP enzymes are going to slow down. So the other is with this, the data is really limited. I've spent a fair amount of time. I picked the brain of other experts. Me defining experts as board certified addiction medicine physicians, and multiple of them, into what am I missing in the literature? Where does the genetic testing and the therapeutic monitoring, what data is there? And there really isn't any. And then considering insurance companies generally don't cover the testing for substance use disorder, our patients may have a hard time paying for it. If you're able to get the testing, it's kind of nice to have it one and done, because then the patient is going to have that the rest of their life. But from an addiction standpoint, I'm not prescribing this. So I just wanted to kind of pause here for a moment, ask for any questions, see if I've been overly confusing to anyone. I'm not seeing the chat blow up, and I know Rana's looking at seeing if there's a bunch of people falling off, which is another sign that we're not doing or I'm being confusing too. All right. So in the final stretch here, looking at the package insert, we adjust the dose of buprenorphine based on the patient's level of withdrawal and cravings. These are subjective and titrating and treating a patient, not a number. And this is also looking at some metabolite testing. And I just wanted to cover this real briefly because, as I had mentioned before, one of the things that we're always looking at is, are we having compliance with treatment? And is somebody cutting a little bit of a corner off their bup tablet, and we're finding it in their urine? So as a reminder that naloxone or naloxone metabolites would indicate that the patient's either improperly using their buprenorphine, or they've recently had an injection or received an IV or intranasal dose of naloxone. All right, so my recommendations is to titrate the drug based on patient symptomatology. We know that the survival data is profound, and of the most profound of any treatment, any intervention that we have in any specialty in medicine, and that's to treat the patient, not the number. Titrate it to making the patient comfortable. That drug testing to limit it for compliance. And I personally use the immunoassay, the screen, but if a patient has a difference of opinion or can't explain the results, then I do then I ask for that sample to be confirmed, at which point then I confront the patient and say, I trusted you on this first round, now you've got to trust me on the second round, and say that the test isn't in error. And I again, the CYP genetic testing I don't do routinely either. All right, so this is my section for questions.